this afternoon. I'm getting carried away with myself. I think we're just going to have a general discussion this afternoon about how we're coping with lockdown, how it's impacted our lives and your work directly and indirectly. And then we've got, well, quite a lot of questions have come in, so I'll be putting those to you both, and perhaps we can have a discussion about those questions and see how much we can get through in the next hour. So yeah, just to kick off, Eileen, can you perhaps give us a bit of insight into how lockdown has affected your work and that of the Royal College of Nursing, and obviously the many thousands of nurses that you represent?
Yeah, so from the Royal College of Nursing, we have been home working, which has been a significant change, but we're all managing really well. Unsurprisingly, our work has been dominated by the pandemic since it started. You may know that the RCN is both a trade union and a professional Royal College, so it's been our role to ensure our members and the patients are safe. We've been working with employers, government and policy makers to ensure nursing staff have the correct protection and the resources that they need. Working and advising government, influencing across the UK on nursing issues, and as they work to respond to the pandemic, listening to the questions and concerns being raised by our members, which have been many, from healthcare support workers and students, registered nurses across all health and care sectors. So yes, and we've done an amazing amount of work to ensure our members have the information that they need and have their questions answered. So yeah, it's been a really busy time.
Yeah, I bet. I can only imagine the volume of questions that you're receiving at the moment. And Kylie, with your work in the British Heart Foundation, how has the COVID-19 pandemic affected that and your partners within that third sector?
So it's been much the same as Eileen kind of pointed out. You know, we're all home working now. Our offices have been closed temporarily, so that's taken a bit of getting used to. And we've used a lot more Microsoft Teams, so I'm getting used to speaking to colleagues virtually as opposed to face to face. Similarly, it's been a really busy time for us as well. So we're a charity who funds medical research. So in terms of the research environment in the UK, we're working to understand the challenges of our funded researchers and feed that back at a policy level. Obviously, social distancing makes everything more difficult. So there are knock-on impacts for universities and labs and things like that. We also provide information and support for people with heart and circulatory disease. So we've done a lot of work in sort of updating our website, making sure that there's expert information. And as I was, sort of talking about earlier on, there's the information comes thick and fast. So getting through it and making sure that we're keeping on top of it is, a pretty big job in itself. And yeah, I think just sort of the charity sector as well is obviously under a particular pressure in terms of, we've had to close our shops temporarily, fundraising events have been cancelled, so sort of feeding in to policy level at that on those sorts of issues as well. So a wide variety of challenges.
Yeah, and Eileen, could you perhaps expand on any particular impacts at this time, this incredibly busy time, on frontline staff? Am I correct in thinking that nurses make up some 40% of the NHS workforce?
Yeah, you're right. I think the pandemic has affected nurses and healthcare support workers in so many different ways. Many have been redeployed from the areas that they normally work in. Nursing students have had their programmes interrupted with emergency standards put in place by the NMC, and some have chosen to do clinical work on paid placements, which is different for them because they're not supernumerary as they normally are through their programme. Some have chosen to continue the academic route, but for their own personal reasons, whether they're shielding or family members are shielding, they've chosen not to take up the paid placements. Retired members have returned to the workforce across hospitals, community and care home settings. So it's been really challenging. Changes in skill mix, changes in number of registered nurses per patient. If you look at intensive care units, it's normally a one registered nurse, experienced intensive care nurse, to one patient. That changed during the peak of the pandemic. So intensive care nurses were supervising other nurses who'd been redeployed to that area, or even other healthcare professionals who had volunteered to help. So I think nurses have demonstrated their professionalism, their unique contribution to healthcare, health and social care across Scotland, across the UK, and really have pulled together to provide quality care in a difficult time.
Yes, and Kylie, I know from discussions I've had with organisations like your own that where we see staff redeployed into different specialties, it can impact on the normal day-to-day care that perhaps people with heart conditions might expect. Is that an area that you're receiving correspondence on? Are you working with the NHS on that issue?
Yeah, so one of the major areas where that has been the case is in cardiac rehabilitation. So that's an intervention that supports people to reduce their risk of admission to hospital after they've had, a readmission to hospital after they've had a heart attack. So it's very important in terms of avoiding admissions and particularly at this point in time, when we want to keep people sort of safe. The most of those staff, because specialist nurses in cardiology are particularly skilled in certain areas, a lot of them have been redeployed into the frontline of COVID. So particularly cardiac rehab services, we're noticing that they have either ceased their service or they've reduced it down to sort of skeleton virtual service. So we've been working to sort of support alongside that in terms of we've provided some digital content that some of the skeleton services can refer patients onto. Of course, this is to complement the service when it comes back, but also just to see us through this kind of difficult time where those aren't available. Similarly, there was a concern around people with heart failure and the specialist nurse support that would be available to them. I think that most services across Scotland have retained at least a skeleton service for heart failure, which has been really important. I think that the main thing that we were hearing a lot of was this uncertainty around redeployment and this kind of panic about, will it be next week that we'll get redeployed, and then what are we going to do then? So I think that most of them have retained a skeleton service, which has been good, but social distancing also makes it quite difficult because you can't do as many face-to-face visits and things like that, and some aspects of care require to see the patient. So that's presented the challenge for some areas as well, I think.
Okay, no, thank you both for just sort of setting the scene there about work that's ongoing and some of the particular challenges at this unprecedented time. As we've got quite a long list of questions, I'm going to kick off with question number 1, which has come from Malachi, and he is asking how the COVID crisis has impacted the physical and mental health of frontline workers. So, Eileen, perhaps you'd like to expand on that. I mean, are staff able at this time, those working in health and social care, are they able to meet their own basic needs? Because I know even pre-pandemic, I was being contacted in cases where health and social care workers were simply not finding the time to have a break, to have a drink of water, even to visit the bathroom. Is that side of things being looked after? What are those impacts at the moment?
Yeah, so the RCN has put out guidance. You'll know, Alison, before the pandemic, we had campaigns, around nursing staff having proper opportunities for rest, to rehydrate and proper breaks. and that work has been ongoing, and I think it's been more crucial because of the wearing of PPE, the personal protective equipment. I don't know if anybody has tried wearing one of these masks for any length of time. And the rest of the PPE, it's very hot. You're at risk of dehydrating. So we really have pushed for nursing staff to have proper rest periods, to be able to have their days off, to get away from their work, have some downtime. We've also released a lot of resources for our members around resilience, mental health. Look after yourself. It's okay not to be okay. To reach out, we've got a number of services for our members. I also know many of the boards have put in support for all staff during this time. They have restrooms. They're getting access to some counselling support, etc. So I think it's been challenging, and I'm not saying it's all been put in place, that people aren't struggling, people are struggling, but the message is please reach out, don't struggle alone. If you're not getting the support from your organisation, your employer, then we are there to offer some of that support.
Mm-hmm. Is there anything you'd like to comment on there in particular, Kylie, with regards to the impacts on frontline staff?
Just to support really what Eileen had said, and it's kind of unprecedented circumstances that they're working under, disruption to their usual working environment, things like that. So BHF does have some information and resources on our website for cardiovascular clinicians. So we've collated a lot of the guidance and stuff like that, and there's some stuff around wellbeing as well.
And can I ask, Eileen, we've had a tremendous response from people wanting return to work. Coming over, you say students who've not quite finished the study they were expecting to complete, that formal study. I've heard that 22,000 students and returning healthcare workers have volunteered themselves, and the numbers are, they are remarkable, and they just show how committed people are to help. Has that helped?
Quite clearly it has helped. You'll know, before going into the pandemic in Scotland, there was like 10,000 nursing vacancies, so we're starting from a deficit anyway. So having the returners and the students working in paid clinical placements has absolutely helped bridge that gap. I think we're not at the end of this road yet, and we are really pushing for a robust workforce plan going forward. And many of the asks that we asked through the development of the safe staffing legislation that was passed by the Scottish Parliament, was going through the developing the guidance stage, many of those asks are still there and shouldn't be forgotten in terms of ensuring safe and effective care to patients, whatever setting they're in, but also looking after the well-being of the staff.
Yeah, I'd like to think, I'm very hopeful. The pandemic has certainly shone a spotlight on the essential work that those in health and social care do, and my neighbourhood last night, everyone is out, as they had been for weeks, clapping for our carers. But that absolutely cannot be the end of it. Indeed, it has to only be the beginning. If it's getting people to think about carers, then they have to commit to investing properly in that workforce. I think it's absolutely key. This cannot be about, the applause is meaningful. It is meant with the best of intention, and we have to build on that intent, I think.
Absolutely.
Our third question, and thank you to Sarah for that previous question about returners, is from Cass, who's asking about the role of technology And how can the NHS reduce digital and IT inequalities, which could now have a more significant impact than pre-COVID? There are many examples here. I mean, I believe that the digital divide and the social divide they're obviously connected in many respects. And even discussions we've had recently about the proposed app. We know how many people don't have access to technology or just simply aren't very good with technology. How can we go about ensuring that inequality isn't exacerbated by the digital divide? So I'll pass on to Eileen first and then to Kylie.
And I think that's a really good question. I think we've all had to embrace technology in a different way because of the pandemic, and whether it's because we're working at home or the rollout of digital technology and remote clinics, etc., the near me technology for consultations in health. I think technology has the potential to both reduce health inequalities by enabling people to access digital health information, etc. But there is a risk that it does widen those health inequalities if people don't have access to the technology. So we need to work collectively to improve health literacy, have better choice and convenience of services that suits individuals in our day-to-day lives. But let's not forget the value of face-to-face consultations. I think there is a danger that we throw the baby out with the bathwater, because this has worked for people, but it's worked because we're in a crisis. So let's take the learning from that crisis, but let's not widen the health inequality gap.
Mm-hmm. And Kylie?
Yeah, so I think it's a really good question as well. And already we see the inequalities in terms of the impact of heart and circulatory disease and the impact of COVID-19. So people who live in areas of socioeconomic deprivation are, disproportionately affected by both, Black and minority ethnic groups as well, disproportionately affected by both. And the potential for our response to COVID to maybe heighten that is, something we've got to be really mindful of. I think that similarly to what Eileen was saying, it's digital, and this is, it's the direction of travel, and it's positive, and there are lots of good opportunities out of it. But I think that what we have to do is sort of threefold. So we have to make sure that we're evaluating these new models with health inequalities in mind, so that we don't just assume that they're working well for people. And that in evaluating them, we're speaking to people who, have real life experience of these services. I think, again, just to reiterate the point about bringing back face-to-face, I think as soon as it's possible and in line with the roadmap that the First Minister set out, I think we need to be discussing how to bring back face-to-face services, because digital complements it. It's not a replacement. And that makes sure that people have a bit more choice. And also there's maybe something around thinking about how we help support people with access to digital. So, when we did some work on high blood pressure, that's a particularly big area for home monitoring. But some of the concerns are around inequalities around access to a blood pressure monitor if it costs £10-12 for one. So is there some way to make those available to people, whether it's through prescription or some other model where we can seek to actively address and give people opportunities? So that's my kind of thoughts on those.
Yeah, I mean, I think the First Minister yesterday was speaking about the need to roll out access to iPads to young people who may not have that at home, or families where 4 children are sharing one iPad. We simply can't make assumptions that everyone has access. And I know from my work on Social Security Committee, when you're moving towards the DWP with the digital by default, just an assumption that we all know what we're doing. There was an upsurge with Citizens Advice were telling us that they were spending a lot of time teaching people how to log on to computers. So I think we've got to be very, very careful that we don't assume that this is part and parcel of people's everyday lives. And, you're quite right. We will never replace that, interpersonal face-to-face appointment with technology. But I think it's important at the moment because, we've seen how vital it is for communication and making appointments during the pandemic, that it is rolled out, as widely as possible. I think it has to become part and parcel of our everyday lives, and we do have to start doing that at school. And it's clearly the case that, even within schools, there's different access and provision online for people learning and so on. So I think that is a very good question, and one that we need to keep an eye on. We certainly don't want to be widening health inequalities, which are already so prevalent in Scotland. Now, our next question is from James, and it is, what interaction is there between the health and social care sectors, and how does this support patients? And then a huge question, would it be easier if social care was run publicly? Now, my own personal view is that it would, and that I believe that's my party's policy too. And I just feel that we've seen in the recent weeks, I think health and social care integration has obviously been the overriding big discussion, over the last few years in the Health Committee and beyond. I think it's fair to say that it's been moving too slowly, that the budget hasn't always followed the rhetoric when we're looking at having more care in the community. So there are clearly challenges there, but I'd just like to get your views on those big questions. I know these are fairly massive questions, so don't feel, I don't expect you to have all the answers, but as people who are involved in health in Scotland in prominent roles, what's your view on that, about how the health and social care sectors are working together? Natalie, sorry, do you want to start off?
I'll start. So I think, integration makes a lot of sense to make sure that people can receive sort of seamless care throughout the whole journey. I'm not entirely sure how well it works in practice. I'm not involved in the delivery of care, so I suspect if you spoke to clinicians or people working in social care, they might have their own particular views about how well each side integrates with the other. I think probably don't want to share my personal view as someone here representing BHF, but no, I definitely think that there's much more we can do to progress that sort of whole system approach to care.
Mm-hmm. And Eileen?
So we've had health and social care integration for a significant amount of time in Scotland. I think there are huge benefits from that integration. It's probably moved slower than people would have wanted it. I think the pandemic has shone a light on that there is much more to be done. And healthcare is not just about hospitals. And I think initially in the pandemic, the emphasis was on hospital care. And I know as an organisation, we were saying don't forget the community care for hospital care to succeed and not be overwhelmed. You're still going to have to provide services in the community, provide support to, don't forget the district nurses, don't forget the health visitors, don't forget the care homes and the staff that, who do an amazing job in our care homes. So the crisis has really highlighted challenges faced across health and social care, and that maybe we need to work together to learn from what has went well and what's not gone quite as well, and how we improve going forward.
Just to add to that. Sorry, I interrupted you.
No, it's okay, carry on.
No, just to add to that is, I think one of the challenges that we sometimes have is the lack of data and information about services in the community, and that makes it difficult to argue, to make a case, build a case, because the information and the data isn't isn't there. So I think that we can definitely get much better at showcasing what's going on.
Yeah, and to go back to the previous question, it's sharing that data and information. So we still have systems that don't speak to each other. We still have, district nursing teams who don't have access to the digital technology. Let's learn and start sharing the data, sharing the information.
Yes, yeah. I mean, I think we're learning so much at this time about what is working well and what isn't. And I think, we've been given an opportunity here to perhaps better understand what care in the community really looks like, because clearly there are excellent examples of where it's working very well, and then there are others that have led to such grave concerns that the government has had to step in and intervene. The particular care home incidences that I'm talking about, I do think we have to learn from what's working well. We've had some feedback to that earlier discussion on information technology from Jennifer, who's making the point that actually some people are very happy with an online appointment. They would prefer that for whatever reason. So I think it's just always bearing in mind that one size doesn't fit all. But I do think once we get through the huge challenge that this emergency is presenting, I mean, I've been calling for a national conversation on what it is exactly that we expect the NHS to deliver, but I think we have to have a broader national conversation about health and social care and how they should be paid for and how they should be delivered and what people are actually prepared to pay for that service. We can't expect everything and then balk at the thought of funding it properly, but I think that is for another day. So our next question here is on testing, and that's certainly a huge question and one that's been taking up a great deal of time and focus in Parliament and without. So what's your view on testing? Have you been tested yourself, and are we doing enough testing? Now, you don't have to share any confidential information here, so please be aware of that. But Eileen, what, as someone who's so closely involved with so many working on the front line, it'd be good to hear your views on this.
Okay, so as you know, we've been supporting your calls for routine testing for health and care workers, whether or not they have COVID-19 symptoms. We need to help to detect cases early, reduce transmission in hospitals, community settings, and better protect staff and patients they care for. So yes, I think we need to widen testing. We need to improve the testing infrastructure. Are we doing enough testing? Probably not, but we need to be aware of the implications of widening that testing. The more you test, the more asymptomatic positive staff you're likely to find, whether that be in the care home setting or the hospital setting. So that needs to be planned for. Have I been tested? No, because I haven't been out this room for weeks, so I haven't had the need to be tested. But I think, as we slowly exit out of lockdown, clearly there will be a need for wider testing, and not just testing, but that test, trace, isolate, get the proper infrastructure in place to allow that to happen, so I can eventually get out of this room. Sorry.
No, thank you. Kylie, and what's your view on testing?
Yeah, nothing really to add to what Eileen said there. That pretty much covered it very extensively. I haven't been tested because similarly I've not been out of my house in God knows how long, and have not had any COVID symptoms. And the only other thing to add is just that BHF has supported some of our infrastructure to become available for testing. So we've got labs at Imperial and Glasgow University that are now supporting with testing, and we've also enabled some of our PhD students to be redeployed to that effort as well.
Okay, thank you very much. I mean, I think this is an area that we've spent a considerable amount of focus on with our our small team in Parliament, because we think it is so important. And I would just like to thank all those academics and organisations who have helped us highlight the issues here, because I think at the beginning there was very much a focus on only testing people with symptoms, and there's so much research and evidence now which makes it abundantly clear that you can be asymptomatic, feeling pretty well, and actually infectious. And you just have to think about the implications for someone who perhaps doesn't only work in one care home, but in 2 or 3, who's, absolutely unintentionally spreading this virus. And that has been a huge concern for folk working in health and care. And that's where a lot of correspondence has come from. So I think the message is it's becoming more widely recognised. The government is constantly expanding the testing programme, but I think I would say that it's not where we'd like to see it as yet. I mean, if we want to be able to move from lockdown into a situation where restrictions are gradually lifted, the whole time we have to be ramping up our capacity to test, trace, isolate, and quite rightly, this government advises, support people in that isolation if that's what is required. I think there's a way to go on this as yet, and there's obviously a way to go with lockdown, which we clearly support. I haven't been tested myself yet. I have been adhering to the rules very closely. We've been in Parliament on a few days but are socially distanced and so on. I would really like to see, though, the fact of the matter is our testing capacity in Scotland remains significantly underused, and I think that's a great concern when there are so many people who could and should be tested, those working in health and social care. And I think there's a duty on us to make sure that's made as easy as possible for them. We can't expect someone at the end of a 12-hour shift to make any sort of journey whatsoever. We know that they will be exhausted. We know that they might have spent hours in very uncomfortable PPE, which I should say, it's been brought to my attention during this pandemic, is largely made for the male body and or head. So there's work to be done there for sure. But I think testing is an issue which will be discussed on an ongoing basis as we proceed. And it's the First Minister has emphasised that this is not a magic or silver bullet, but I don't understand how we can seek to prevent the spread of the virus if we don't fully understand where the virus is. So that's my thoughts on testing. Now, the next question, and thank you, Sam, for that question. The next question is from Robert, and it's about charity. So I think over to you on this one, Kylie. What impact has the lockdown had on the operation of charities like the British Heart Foundation to support those people it normally would?
So our charity, as a medical research charity, kind of has three strands of people that it supports in terms of we fund a significant amount of research throughout the UK. So we have our researchers and our research chairs who are involved with BHF. And that ranges from everything from PhD students up to the professor chairs. And we also support people with heart and circulatory disease, and we work closely with clinicians in the NHS as well. So there's sort of 3 different areas of support really that have been impacted by coronavirus. So to touch on the patient side of things first, we have done a lot to upscale our digital information. So there's lots of information on our website, which is bhf.org.uk for anyone who's interested. There's lots of information, expert information on our website, support. We have a forum for people with heart and circulatory disease if they want to chat to other people who might have the same sort of issues, things like that. We've also upscaled our heart helpline. So that's a helpline we have staffed by cardiac nurses who are there to offer support and advice to people with heart and circulatory disease. That also in some ways supports the NHS because people are able to speak and get advice in that way. Maybe might not phone their GP, or they might get the advice that they need through phoning our helpline. That's had 11,000 calls since March, which is at the peak, it was about 4 times its usual capacity. So a lot of our nurse staff have been redeployed sort of to support with the Heart Helpline. We're supporting researchers to research COVID, so we're providing funding for research that looks into the impact of COVID on heart and circulatory disease. There's a project in Glasgow University at the moment looking at that impact, and we've also partnered with the National Institute of Health Research to support flagship research projects. And we have online hubs as well for our researchers and for medical professionals. So a lot of work ongoing, I think, to support people.
And there's obviously particular challenges at this time with regards to fundraising. I know many charities have had to close high street shops that are obviously a source of income, and a sort of source of awareness raising. I mean, I know we're still passing them by, but we're not maybe popping in and getting that input. So how is this impacting on your fundraising, and how are you still able to help the most vulnerable who need the specific help that BHF, for example, bring?
Yeah, inevitably it has had a massive impact on our fundraising. So we do have charity shops. They've all had to close in order to keep our staff, volunteers and the public safe. So they're temporarily closed, which is a massive income stream for us. Similarly, we've had to cancel lots of fundraising events, these types of things. Another important income stream. Lots of people have been getting in touch asking how they can support, and again it's through making donations, which can be done online. We're also this month running My Marathon, which is like a virtual challenge, so people run a marathon over the course of the month and fundraise. So ideas like that, sort of things people can do at home or outdoors in accordance with the lockdown guidance. And just trying to learn probably and be a little bit fleet of foot in terms of how we respond and how we support people.
I know my Green colleague Andy Whiteman and I were having a discussion, because I think a lot of us have had some time to do some house clearing out. Perhaps going through those cupboards and wardrobes, and I can imagine there will be a lot of people keeping a lot of things to bring to charity shops when they reopen. Are you expecting to be inundated? And do you have any, I'm just wondering if we need to have a bit of a national effort to have a bit of warehouse capacity, because it would be such a shame if people ended up landfilling perfectly good clothing and household items that could be sold in your shops.
Yeah, our retail arm does a lot in terms of, shifting things from landfill. So I think it would be a shame if we weren't able to meet capacity. We're more than happy to receive everyone's donations after lockdown. I'm not too sure about what space capacity and things we have, but I'm sure our retail team are on it and are preparing for an influx.
I'm sure they are. Yes, thank you for that. And thank you to Alice, Robert and Ian for those questions. Now, can I just before we move on to the next question, which was on shielding, just about that interaction between the NHS and the third sector. How do they both work together to support vulnerable people? Do you have dialogue there?
Yeah, so it probably varies depending on what the third sector organisation offers. So some organisations offer delivery of services, which is not what BHF does, but what BHF does is sort of fund pilot projects, and we support clinicians on the front line to kind of feed in issues that are affecting people with heart and circulatory disease. So a lot of that feeds into our policy development, things like that. So we usually have that interaction. So that's something that's ongoing, not as a result of COVID, that's ongoing. But through the COVID epidemic, what we've done is we've responded to some of those issues. So I mentioned earlier about the cardiac rehab situation. Our response was to produce a digital tool that we've made available to clinicians across the UK to signpost to, and we've worked really closely with them on that. And again, sort of, enabling some of our researchers to go back into the NHS as frontline clinicians. Similarly, some colleagues within BHF who are nursing staff have gone back to frontline duties. So I think we have quite good interactions with the health service and work quite closely with them.
And from your side of things, Eileen, from those working within the NHS, the people that you represent who do work within the NHS, how do you see that interaction with the third sector best helping vulnerable people?
So from my experience, I've worked previously in the NHS for too many years to admit to. I know from experience working with a variety of charities around research and enhancing services like the British Heart Foundation, Chest, Heart and Stroke. A variety. I've had 2 calls today with Alzheimer's Scotland, looking at how we can support developments in the early detection and treatment of and prevention of dementia. So I think we all work well together with a common goal, which is to enhance services and improve outcomes.
Thank you for that. Now, our next question, which I'm going to pass back to you too, Eileen, is a question around shielding from Joan. How long will I have to shield, and is there any phasing in of lifting the shielding? I'm finding the 11 weeks that I've spent in lockdown is having a negative effect on my physical and mental health. I'm very well aware of how to take care of myself, and yet the impact is huge for the older generation and many who have underlying conditions. Is there any information or advice that you can give to Joan, Eileen?
So I think that's a good question. There's lots of evidence around reducing mobility in elderly people in particular who are having to shield. My mum and dad are both in their 80s and they've been shielding longer than the 11 weeks. But yeah, I think we await the advice from the government in terms that they would review the 12-week shielding advice and how they can support people who are shielding to be safe, but also how we in the wider public can help protect those that are shielding in terms of allowing them a bit more freedom and to integrate back into. It won't be normal life, but to work towards what was normality. So I think we need to wait and see what that is like, and I think it'll be crucial around the testing, the tracing, and isolating and support. So I await the advice that will be coming out at the end of the 12 weeks, the initial 12-week shielding that was put in place. I think it impacts many people with not just the elderly, but there are clearly nurses who are shielding because they've got underlying health conditions and they've been keen clearly to get back to work. So how do we support those that are needing to get back into the workforce, to get back into that workforce safely?
I know, obviously those with underlying health conditions and those over 70 and so on have been told to, just to take very good care of themselves in order to best protect themselves. I know that a lot of people feel frustrated. I've had correspondence from older members of society who, are rightly pointing out, actually, they may be healthier than many people my own age. I don't hide the fact I'm 54. They're pointing out that there can be very healthy 75-year-olds, very unhealthy 34-year-olds, and feeling some frustration there. But of course, the government they're looking at the best scientific advice they have, and clearly they're focusing on those groups who have been most affected. But this is a very, very difficult time. And I think, Eileen, you make the point there that if wider society adheres to social distancing and the measures in place, it makes it much easier for those who have particular health conditions and so on to integrate. We move to a situation where that is possible. I would just say to Joan there, the First Minister, in her statement yesterday, began to speak about the next steps. There's going to be more detail next week, but that first phase, that initial period, ends on the 18th of June, and more details are going to follow. And I think she has committed to ensure that there's more support for those shielding. I mean, we cannot expect people to live indoors indefinitely. That is, that is not, that is a very challenging life to, there's much more that we have to do to make sure we enable that safe integration into normal society. And I look forward to being involved in that discussion because I think it's a big and important one. So thank you, Joan, and don't hesitate to get in touch with me if there's any specific questions that you'd like to take further. Now, our next subject is kind of, I see there's a couple of messages come on as well. So I've got a question here from Indra, which is about how you discuss the links between welfare cuts and health inequalities. There seems to be little mention of this in the government's roadmap. And Andrew has written with a comment, and he is saying, what's my take on the introduction of a universal basic income for all, bearing in mind we could of course fund it by scrapping the upgrade of the obscenity we call the Trident nuclear weapons programme. Now that might be easier for me to come out and say what I think here, but yes, Andrew, I mean, I agree wholeheartedly. We should, get rid of Trident entirely. It is an obscenity, and it's certainly not my view that that's keeping anyone safer. On the contrary, but I've just been astonished, and yes, the number of parties who've got on board with universal basic income is quite overwhelming. It's been Green Party policy since I joined, and that was over 20 years ago now. So the fact that we're having mainstream discussion about providing people with an unconditional basic income, I think that's really positive, and it's not being poo-pooed. I've taken part in manifesto discussions or manifesto press conferences where it simply wasn't taken seriously, and now a huge range of academics and politicians are talking about it as if they too had always supported it. So I'd like to see some more progress on that. And I think that ties into that link between welfare cuts and health inequality. I mean, I'm in no doubt that the UK government's welfare reform have had a very damaging effect on many people. In fact, the UN chief, the UN rapporteur on poverty, when he was here, Philip Alston, said that you could look at those cuts and think that a group of misogynists had locked themselves in a room and come up with the most harmful policies they could think of when it came to damaging the incomes and therefore the lives of women and children. So I think that link is there, and it'll be very interesting to see what analysis is made of the impact of COVID-19 on socio-economic, those whose lives are much harder because of financial inequality. It'll be really interesting to look and see what impact it has on, we need to understand, we know it impacts on older people. We know that there are concerns about impacts on obese people. I think the links to obesity and poverty are well made and growing, but I think it will be very interesting to look at the impact of poverty on this disease and our resilience and our ability to fight it. And that, I'm sort of going on now to the final question, but we can have a broader discussion of all these issues now, which is from Helga, who's asking if I would agree that public health and the Chief Medical Officer should put more emphasis on boosting an individual's resilience with vitamin D. I absolutely think that we should. We can expand on this in a moment, but I think if we want to ensure that we're all optimally resilient, that our immune systems are as healthy as possible, then we have to do that by making sure that people have a decent income, that they're living in a decent home, that they have access to nutritious, wholesome food. So I've just kind of given you a brief trot through what I think there. I mean, I think in this session and the last, I've very much tackled I think our poor health through a desire to see us make the most of every lever that Scotland has to boost people's incomes. You know, that's why we've ensured that the Scottish Government will roll out the Healthier, Wealthier Children programme, which is about health visitors and midwives seeking to ensure that the families they work with know what they're entitled to and claim those entitlements. We know that there are billions of pounds of unclaimed welfare benefits in the United Kingdom. So I don't know who wants to kick off first with that topic, but it's about how we ensure that the folk know what they're entitled to, access that entitlement, and that link between welfare cuts, welfare more generally, and health inequality. I'm going to give you the floor, Kylie, and then over to Eileen. And take your time, be expansive. There's a lot in there.
So it's not an area that we typically cover from a BHF perspective. So when I'm talking here, I'm talking, you know, probably from a personal perspective as opposed to a representative of my organisation. But I do agree that we've definitely seen a bit of a reckoning in terms of facing the consequences of austerity and things, you know, and things like that. It's highlighted some of those in a way that people can't avoid. Basically, I think. There is some data that shows that COVID has a disproportionate impact on people who live in areas of socioeconomic deprivation. And we already know that health inequality, you know, health conditions kind of have that impact anyway. So if they have an impact on COVID, you would expect to see that. And I think that, you know, we have to do all we can do to address that. So I think it's really important for our response going forward. The universal basic income stuff is really interesting. It's not a sort of policy that I've looked at in detail from my work's perspective, but one of the things that we are concerned about is what we touched on earlier about people who have health conditions as we move out of lockdown and they're going back to work. And if we think about it from the perspective of health inequalities, those jobs that are most exposed to COVID-19 will largely be lower paid jobs. So that might also impact on inequalities. So what people do in terms of whether they feel confident going back to work, if they feel like they're working in a safe environment or not, and the safety net that's there for those people if they can't return to work, you know, at that point. I think that's something that really needs to be considered. I'm not quite sure what the answers are, but I definitely think it's something that we as a society need to think about.
Thank you, Kylie. And to Eileen?
I think there's some huge topics in there. I mean, the link between deprivation and poor health outcomes has been known for decades. I think it's been known as long as I've been a nurse, in terms of the socio-economic impact on health outcomes. So, yeah, I don't think I could expand on that. It's well known, but as a society, it's time to take action, and I think COVID highlighted it. I think, as Kylie said, there is emerging evidence that those from more deprived, socially deprived backgrounds are having poorer outcomes, are at more chance of catching the virus. So yeah, it's just the pandemic has put a spotlight on a lot of things that were already in existence, but it's highlighted the inequalities, it's highlighted the poorer outcomes, the issue of the BAME community, being at more at risk and having poorer outcomes. So much research needs to be done to find out what is the link, and I think today or yesterday it came out about people with type 1 diabetes having poorer outcomes. So there's lots of work to be taken forward. But yeah, we've as a society we have known for a long time about the links with deprivation and poorer health outcomes, and that's from poorer the education outcomes, etc., and your life chances and your life choices. So yeah, I don't know if I can expand on what the two of you have said around that.
Do you see that link between deprivation and those suffering poor heart health, Kylie?
Yeah, definitely. So I think it's something like you're twice as likely to die of heart and circulatory disease in the most deprived area compared to the least deprived. I think that's the stat. I pulled it off the top of my head, so it may be incorrect. Don't re-quote me, but it's substantial anyway. We definitely see it, and I think that underpins some of the impact. That might have an impact on some of the outcomes we see from COVID, but definitely there's a link with socioeconomic deprivation. Yeah,
there's clearly a lot of research that will be undertaken as a result of the pandemic. I think that Black and minority ethnic people have been found to be twice as likely to have a poor outcome from COVID. And I think there are questions, Kylie, you're pointing out that if you're in those who are working in the most poorly paid jobs are the ones who are most likely to find themselves often in the front line of work that brings them into contact with people during the COVID epidemic. So there's a lot to be looked at there. There's also I've lodged a series of questions on the impacts on particular groups of people in our BME community, on those with various underlying health conditions, on a range of people, and also looking at the impacts that vitamin D, for example, might have on those particular populations. There's a lot of work to be done yet. Now, we've got time here for a final question, I think, and it comes from Carol, who is asking, I'll put this to you first, Eileen. Is there any move to make masks compulsory inside public places? It would help greatly for others to feel safer when out and about. Now, my understanding at the moment is the First Minister has her guidance to the wider public is that we wear face coverings when we're in enclosed public spaces like shops and so on, but that it's not compulsory. So that there are countries where it is compulsory. That's not the case here at the moment. We're very much focused on making sure that those working in health and social care have adequate and optimal PPE, because that has been an ongoing and very concerning issue throughout. But do you have any comment to make on that wider use of face masks or coverings?
So I think, again, there is emerging evidence around face coverings. So as you quite rightly said, it's a recommendation that you wear a face covering if you're inside, say, a shop, a supermarket, to reduce the spread. I think the evidence is it's so if you're wearing a face covering like a cotton mask or a scarf or something like that, clearly not a surgical water repellent mask, because we need the PPE for the frontline staff, that you may not be protecting yourself, but you're protecting others. So I think it goes back as, what are we going to do as a society to help protect each other and reduce the spread? So as I said, it's emerging evidence, but I've read quite a few papers or systematic reviews of the evidence that it seems to be coming out that there is some benefit into the public wearing face coverings, and that's not an RCN position. I need to say that's just by my own personal interest in reading the evidence, but it's not compulsory. I don't know if that's something that may need to be considered as we move forward. My experience is not many people are following the advice, but that's the advice at the moment.
Yeah, I think it's fair to say that's probably my experience too when I am in shops. And it will be interesting to see as lockdown is lifted gradually, whereas, people begin to adopt that as a more natural habit. When you are out and about more and more likely to be indoors in various places in the day. Just wondering what your views are on that one, Kylie.
Yeah, again, I don't have a particularly strong position on it from an organisational perspective. It's not something that we've kind of taken a stand on. But yeah, I think it does seem like the evidence is kind of emerging as we learn more. But also, I can't see huge unintended consequences of it. So, I can't see huge downsides to it. I mean, I'm sure that there might be some, particularly, if people lip read or things like that. But I don't see it as being hugely insurmountable in terms of some of the unintended consequences. So I think, yeah, it's a bit of a balancing act, isn't it, about how much do we trust people to look after others versus how much do we, put it into sort of mandatory terms. So I think I think, yeah, that's a sort of bigger question, isn't it? Like, what can we trust the general population to do? And I think actually what we've shown is that people have really complied quite well with lockdown and stuff like that. And a lot of that is guidance as opposed to some of it's mandatory. But I think we've seen quite a good response from people.
Mm-hmm. Yes, and I mean, obviously, face masks have been worn in other countries for a long time now, who perhaps had more of a direct impact from other diseases, and it will be interesting to see how that develops. But I do think, yeah, as time goes on, if there's something that we can be doing personally to prevent that spread, it would seem a very sensible and appropriate step to take. Now, I'm aware we're just over the hour, and I think this would be a good opportunity to, just to give you the floor to say what you'd like to see happen as we sort of move into the various phases of lockdown, and what we can do to work together to best help and support your own organisations. So I'll pass to Kylie and then to Eileen.
So I think from the sort of health perspective, as opposed to our kind of research or charity side of things, I'll focus on the health perspective. This is what the conversation is about, really. I think we need to make the most of the sort of innovation that's happened during adversity. So some of the changes to models of care that we were talking about earlier, make sure that we're evaluating them in line with inequalities, to make sure we're not exacerbating things. But there's some things that we'll want to keep, there's some things that we won't want to keep. So I think we have to work together to figure out which is which and how to support that. And I think, yeah, just a sort of a more cohesive and collaborative approach to that type of thing. So I know in a pre-COVID world, we were talking about a new heart disease strategy or a plan. I still think that's quite relevant, because what COVID has done has been to highlight some of the issues, and the response is that we need to be more collaborative. We need to set a direction of travel, and we need to really work together to make it happen. So
thank you. Thank you very much, Kylie. Eileen, what would you like to see happen, and how can we best support the Royal College of Nursing and the excellent work you do too?
So I think before this crisis, nurse staffing in hospitals, community teams and care homes was already stretched. It was already an issue, and the RCN has campaigned long and hard around safe and effective staffing. It's one of our campaigns. Change is long overdue, and I would like to see, with public support, we make sure governments across the UK do not forget the professionalism and dedication demonstrated by all nursing staff and healthcare support workers and carers across the UK and across all settings during this pandemic. So we need to build on that and look at the importance and value in investing in education, nursing posts, nursing leadership across all settings, and build a better future for nursing and make it a career of choice across health and social care.
Okay, thank you both. I mean, I think it's fair to say, just sort of in summarising, that we're not going to be getting back to what we regarded as normal. There's going to be a new normal when we think about schools going back in August. What's it going to look like for our young people? What are universities going to be like for students in the autumn term and beyond? I think there's an opportunity here to discuss, yeah, as you say, that more collaborative approach. And I think that's been an important focus for all of us in Parliament. We absolutely have a duty as opposition politicians to be scrutinising government activity as much as we possibly can. But I think when so much of it has been based in recent weeks and months and will be on an ongoing basis on scientific advice, it's really important that we have access to those who can help us understand that advice to be able to offer that better scrutiny. I'm really excited about discussions that we're going to have on a universal basic income, on concepts like a 4-day week. That doesn't mean that people are paid less. It's about, you know, they're paid equivalent for a different way of working, a different way of living, a different way of doing things. Things that we were told could never happen are now happening. You know, we have had, I suppose, members of Parliament who've previously said, I'm finding, you know, the impacts of representing a constituency several hours away incompatible with family life. And here we are making small adjustments that make those things possible and may make it possible for those with caring responsibilities to be more involved in our daily politics and daily discussions. So that is all good. I mean, I think we want to, you know, I can feel it here in this discussion. There's a real heartfelt desire to build back better, to make sure that the Scotland that emerges is that collaborative, cohesive, empowering model that just lets everyone input and ensures that we see equality progress. And the last thing on earth we need at this point is a step back into that damaging austerity that means that people's health and well-being has been impacted, and that you know, some people just haven't had the resilience they might have had otherwise to deal with COVID-19 or life in general. So,
sorry, my doorbell keeps going. Sorry,
okay. Yeah, we've had a doorbell. We can't come in the room. And we've had a furry friend as well. Yes, you see, you don't get that. You know, I think these are kind of welcome little human distractions. Anyway, I'm going to wind up there, but I know that everyone that has been tuning in will share my heartfelt gratitude to you both for giving up this part of your Friday afternoon and for all the work that you're doing out with this conversation, with the British Heart Foundation, with the Royal College of Nursing. Thank you both very much indeed, Kylie Strachan and Eileen McKenna, for your time this afternoon. And I've no doubt we'll be in touch. And if anyone has any questions arising from this afternoon or out with, please don't hesitate to get in touch with me. Thank you very much indeed. All
Thanks
for now.
For having us.